Welcome! We are IPhO Pharmaceuticals, and today we will be taking you through our pipeline process and bringing our drug Vicodex from identification as a new molecular entity known as doxyretin through FDA approval and marketing. Doxyretin is a partial mu receptor agonist whose principal therapeutic action is analgesia, indicated for the treatment of chronic pain associated with rheumatoid arthritis. You will be hearing from executive leaders from each functional area, being clinical development, regulatory affairs, medical affairs, health economics and outcomes research, and finally marketing. Each functional area will highlight key findings from their respective area. Before I turn over our presentation to clinical development, here we have highlighted the disease background of rheumatoid arthritis and its prevalence in the United States. Rheumatoid arthritis, also known as RA, is an autoimmune chronic progressive disease causing inflammation in the joints, resulting in painful deformity and immobility. There is currently no treatment for RA, but the pain associated can be managed. Rheumatoid arthritis affects approximately 1% of the population, equating to over 1 million adults in the United States. On the left of the slide is a preview of the drug monograph created by IPHO's Health Economics and Outcomes Research Department. The drug monograph provides an overview of Vicodex's safety, efficacy, and availability to aid in defining its role in therapy and parameters for its usage. The drug monograph highlights dosing and administration, where Vicodex is available as 20, 30, 40, 50, 60, and 70 milligram oral tablets in intravenous solution. The recommended dose is 20 milligrams once a day or every 12 hours. Equivalent dosing is allowed for oral and IV administration. Abuse deterrent is formulated such that manipulation, including crushing or chewing of Vicodex, renders the drug inactive. Use in specific populations includes that Vicodex should not be used in children under the age of 18 years old. Geriatric patients and pregnant women should use with caution. Dose adjustments are not required for renal or hepatic compromised patients. Vicodex is indicated for the use in managing chronic, moderate to severe pain associated with RA in adults over the age of 18 years, where chronic pain is defined as pain with a duration of 3 months or greater. The mechanism of action of Vicodex is a partial agonist at the mu and nicotinic receptors. At the mu receptor in the central nervous system, its binding will activate the G protein GI signaling pathway to relieve pain. At the nicotinic receptors, it will enhance the pain-relieving properties of the mu receptor while avoiding the addictive properties associated with opioid analgesics. Pharmacological and pharmacokinetic data includes an onset of action of 30 minutes, the duration of action of 3 to 5 hours, minor hepatic metabolism by a CYP2D6, half-life of 12 hours, bioavailability of 85%, clearance of 20 to 30 milliliters per minute per kilograms in adults, and excreted fecally. Vicodex interacts with CNS depressants such as alcohol and barbiturates, and adverse effects includes dizziness, headaches, or feelings of agitation, and serious adverse effects includes chest pain. Now we'll move on to clinical development with Jang.
Thank you, Jennifer. Pictured here is our drug discovery timeline, in which the discovery of our molecular entity doxyretin was found in 2004. Our IND was filed in 2011, and as you can see, the drug discovery and preclinical trials began from 2004 to 2011, and then phase 1 was from 2012 to 2013. Moving on to phase 2 was 2013 to 2015. Phase 3 was 2015 to 2018, and then we filed an NDA in 2018, and then currently we're in phase 4 of clinical trial, and clinical development conducts these preclinical and clinical phases to evaluate the safety and efficacy of the drug. For our preclinical trial, IPhO Pharmaceutical evaluated toxicology and pharmacological effect on mammals, and the mammals we picked was rhesus monkeys. The reason why we picked them was due to their similar genetic makeup to humans, and the methods we used was we enrolled 50 rhesus monkeys as animal subjects. Chronic arthritis rheumatoid pain was stimulated via 5 milligram IV methylated albumin injections. These animals were allowed to administer their own dose of doxyretin during painful episodes. Each subject controlled analgesia pump administered 20 milligram IV of the opioid with a lockout interval of 4 hours. We stopped the experiment at a tolerated dose of 100 milligram due to ethical concerns. The conclusion of the study was there were 0 reported deaths, 0 serious adverse reactions, and it was safe in animals. In phase 1, PHILO Pharmaceutical conducted a randomized parallel assignment open-label safety study in rheumatoid arthritis patients with moderate to severe pain. The objective of the study was to determine the safety of doxycycline in rheumatoid arthritis patients at total daily dose of 10 mg, 20 mg, 60 mg, and 100 mg. Our inclusion criteria include males and non-pregnant females over 18 years old, and those that have been diagnosed with rheumatoid arthritis pain for more than 3 months with a pain scale greater than 5 on the NRS scale. And the exclusion criteria is a past medical history of seizure, epilepsy, and hypersensitivity to opioid analgesic. The method we used was we given each patient an initial dose of doxycycline by mouth 10 mg, and the dose was increased 10 mg every 6 hours to a total daily dose of 100 mg in 24 hours. And the serious adverse events that we monitor were respiratory and CNS depression, and we monitor these events every hour. And the NRS pain scale was used to assess the patient's response. A therapeutic response was determined to be a 2-point reduction for an NRS pain scale. And as you can see on the table on the right, an untolerated dose is defined as a grade of 2 or worse toxicity according to CTAE scale, which is the common terminology for adverse event. And so a pain reduction of at least 2 points was seen in 40 patients at a total daily dose of 20 mg by mouth doxycycline. But when the total daily dose increased to 100 mg by mouth, 2 patients began experiencing symptoms of respiratory depression and the trial was stopped. The safety therapeutic window was determined to be 20 to 80 mg by mouth every 24 hours.
Phase 2 trial was a randomized, double-blind study to determine the therapeutic efficacy of doxycycline compared with morphine in the management of chronic pain due to rheumatoid arthritis at 10 mg, 20 mg, and 50 mg respectively. Participants were selected with the following criteria: males and females over the age of 18 years of age with moderate to severe chronic pain for at least 12 weeks before consent, in addition with a baseline level of ESR greater than 30 and CRP greater than 1.6 mg per deciliter. Participants were excluded if they had the use of MAOIs within 14 days or had a history of seizures, hypersensitivity to opioids, and moderate to severe liver and kidney impairment. In methods, 297 participants were randomized using a computer-generated schedule into 4 groups. 3 groups were given respective doses of doxycycline every 12 hours. The 4th group was given morphine IR 50 mg every 6 hours. The length of trial included a 9-day screening period, 5-day washout period, and 10-week treatment phase. Primary efficacy measures was the mean numerical rating score at week 12 minus the mean numerical rating score at baseline. Secondary endpoints included comparison of analgesic efficacy between doxycycline and morphine, in addition to reduction in weekly measurements of ESR and CRP levels in participants given doxycycline 20 mg. Safety was analyzed based on adverse events and vital sign measurements. Test for efficacy was conducted at alpha equals 0.05. Statistical significant differences in mean changes from baseline to endpoint at week 12 were observed in doxycycline 20 mg, 50 mg, and morphine. Doxycycline at 10 mg was not statistical and clinically significant. There was a 75.9% and 81% reduction from baseline ESR and CRP levels with doxycycline 20 mg at week 12. In conclusion, doxycycline 20 mg and 50 mg were associated with statistical and clinical meaningful reductions in pain intensity as seen in morphine, with the addition of significant reductions in levels of inflammatory markers. At 20 mg, doxycycline was better tolerated than doxycycline at 50 mg. In this phase 2 trial, we concluded that the safe and effective dose is doxycycline at 20 mg.
Our phase 3 clinical trial was a multi-center study which evaluated the long-term safety and tolerability of doxycycline abuse deterrent tablets in patients with rheumatoid arthritis. Long-term maintenance of doxycycline abuse deterrent tablets efficacy will be evaluated. The dosage form used in our phase 3 trials is an oral one that loses effectiveness is crushed or swallowed, hence the term abuse deterrent. It is a formulation that is rendered ineffective once it is tampered with to go through routes either known as or suspected to be potential routes of abuse. Inclusion criteria for our study included patients diagnosed with moderate to severe rheumatoid arthritis condition, treated with around-the-clock opioids for at least the past 3 months, or in the investigator's opinion, quality for around-the-clock opioid therapy for treatment of their pain. Patients taking opioids at least 5 days per week for the past month at an average daily dose of at least 30 milligrams hydrocodone. Patient must have the ability to complete study procedures and attend clinical visits for 6 to 12 months. Females of childbearing potential must have a negative urine pregnancy test. Patients had to have had an adequate medical evaluation for treatment of underlying pain condition and appropriate primary medical/surgical therapies. They must also have written informed consent. Exclusion criteria included patients with any clinically significant condition that would preclude study participation or interfere with the assessment of pain or increase the risk of opioid-related adverse events. Patients with medical conditions that, in the opinion of the investigator, would compromise the subject's ability to swallow, absorb, metabolize, or excrete study drug. Patients who have had a surgical procedure for pain within the last 3 months. Patients with uncontrolled blood pressure. Patients with a body mass index of greater than 45 kilograms per square meter. Patients with hospital anxiety and depression scale score of greater than 12. And patients with clinically significant abnormality in clinical chemistry, hematology, or urinalysis that deviates from the norms of the general rheumatoid arthritis population. The primary outcome measures for our study included the change from baseline in average numerical rating scale at week 12. Participants were asked to assess the average pain intensity on an 11-point NRS ranging from 0, which is no pain, to 10, which is the maximum pain imaginable, by selecting a number on the scale applicable to their pain. Daily pain intensity was a mean of pain intensity scores measured twice in a 24-hour period. Weekly averages during the treatment phase were the mean of the daily pain intensity in the 7-day period from first administered dose. The primary efficacy endpoint was mean NRS score at week 12 minus the NRS score at baseline 2 days prior to randomization. Our study methods included an interventional clinical trial study type, 424 participants in the maintenance phase, randomized allocation, parallel study assignment, open label, no masking, and the primary purpose of the study was treatment. For participant flow, the trial consisted of a conversion/titration phase and a maintenance phase. In the conversion/titration phase, it consisted of doxorubicin abuse deterrent tablets given daily for up to 6 weeks. The maintenance phase consisted of all patients fulfilling the protocol inclusion and exclusion criteria receiving doxorubicin abuse deterrent tablets in a flexible dosing regimen. A flexible dosing regimen is defined as doxorubicin tablets from 10 milligrams, 20 milligrams, 30 milligrams, 40 milligrams, and 50 milligrams by mouth twice daily for up to 48 weeks. Also within the participant flow consisted of our pre-assignment details. Out of the 638 subjects treated with doxorubicin abuse deterrent tablets in the conversion/titration phase, 214 subjects discontinued early, and 424 continued in the maintenance phase. 391 subjects ultimately completed the trial. On the right-hand side of this slide, you'll see the results. The number of participants for analysis was determined by the safety population. NRS was used to measure mean change in average daily pain intensity. The total number of participants providing end-of-study pain intensity score was 391. The mean pain intensity score reported by participants was 0.921 with a standard deviation of 2.2. The secondary outcome measures included a mean change in average Flanagan quality of life scale, a 7-point satisfaction scale which quantitatively assesses the cohort's quality of life. The 7 scale responses were delighted, which would be a 7, pleased, a 6, mostly satisfied, a 5, mixed, a 4, mostly dissatisfied, a 3, unhappy, at 2, and terrible, which is a score of 1. The Flanagan Quality of Life Scale consists of 16 scale items, which are classified under 5 conceptual categories: material and physical well-being, relationships with others, social, community, and civic activities, personal development and fulfillment, and recreation. Under these 5 categories were multiple scale items that were rated from 1 to 7, as mentioned before. The results of our secondary outcome measures were that at the end of the 54-week study, there was a mean quality of life scale score of 6.5 with a standard deviation of 1.9, as highlighted at the bottom of your slide. Highlighted in this slide is the incidence of serious adverse events. Safety was analyzed based on adverse events and vital sign measurements. A serious adverse event is defined as any adverse event occurring at any dose that resulted in any of the following outcomes: death, life-threatening adverse events, hospitalization, or prolongation of existing hospitalization. It is important to note that Dr. Redden had 0 events of serious respiratory depression.
Our Phase 4 trial was a randomized, open-label, multi-center study of the effect and safety of Vicotics in the treatment of chronic rheumatoid arthritis. The primary objective of the trial was to observe the efficacy and reduction of pain in patients taking 20 mg doses of Vicotics. Our secondary objective was to assess potential symptoms of addiction and withdrawal, as well as the frequencies of common side effects. We included patients suffering from chronic severe arthritis pain over the course of 180 days with NRS pain intensity scores of greater than or equal to 5, and excluded patients on as-needed treatment and who had significantly fluctuating pain intensities within brief periods of time, as well as additional criteria listed. Within the trial, we enrolled 50 eligible patients who were screened for vitals, labs, medication, and pain history upon arrival. These patients were evaluated annually to update any changes in NRS pain scores, as well as any development of adverse effects. Listed is data from our primary outcome. We observed a consistent reduction over time with a best score of 3.2, which is 3.7 points lower than the baseline average. Listed is our data from our secondary objective. Across the board, we observed consistently low frequencies and common side effects of addiction and withdrawal. We also observed a trended decrease in symptoms over time. In addition, we also screened for common adverse effects in other opioids. Notable adverse effects included CNS depression, respiratory depression, and constipation. Compared here is the frequency of common side effects observed while taking other opioids such as morphine, Tylenol-3, and tramadol over extended periods of time. In comparison, Vicotics was observed to have significantly lower frequencies of adverse effects, indicating better quality of life. Within the clinical development functional area, PharmDs play a pivotal role in the drug development process. The clinical pharmacist is responsible in contributing to drug discovery, drug development, drug safety, and efficacy. The role of the pharmacist in clinical development is least utilized in comparison to other functional areas. Given a pharmacist's pharmacological and pharmacokinetic expertise, there is much growth for the implementation of pharmacists in the function. And now on to Lauren in Regulatory Affairs.
Thank you, Jason. While the main purpose of regulatory affairs involves submissions to the FDA, we are involved with every step of the development process, starting with the submission of the IND. Regulatory Affairs began working with the Vicotics team in November of 2010 in order to adequately prepare for an IND filing date of November in 2011. Approval occurred after a 30-day period of review by the FDA. To begin with our IND filing strategy, Regulatory Affairs requested a Type B pre-IND meeting. This is the first formal interaction with the FDA regarding the drug. The overarching purpose of this meeting is to get in front of the FDA so that VILO can validate the clinical development program before we begin work and avoid time-consuming errors. A few suggestions Regulatory Affairs had to streamline the process included pre-selecting sites for study participation, sharing draft protocols with study sites for qualification, and beginning contract and budget negotiations all before approval of the IND.
Throughout the drug approval process, the Regulatory Affairs team from VILO Pharmaceuticals remained in contact with the FDA. First, we requested a pre-NDA meeting. This meeting allowed our company to resolve all potential problems before submitting the NDA in order to reduce delays in the initial review process. We decided to apply for Fast Track designation.
Due to Vicodic's significantly reduced side effect of respiratory depression, widened therapeutic window, and reduced addictive properties, it is significantly safer than current drugs on the market. We feel strongly that our product will be very beneficial considering the current opioid crisis. The need for a risk evaluations and mitigation strategy was evaluated by examining other approved opioids on the market. We will continue to submit additional advertising materials, research, clinical trial information, and manufacturing changes to the FDA as time goes on. IPhO Pharmaceuticals submitted the NDA for Vicodix, and it was approved on December 2, 2018. The NDA addressed a variety of topics, including but not limited to safety, benefits and risks, appropriate and complete labeling, and manufacturing processes. Supporting data from IPhO Pharmaceuticals' clinical development team was also included in the NDA. Data from preclinical and phase 1, 2, and 3 trials were included for review by the FDA. A proposed package insert was included in the NDA. The package insert addressed proposed indications, dosing and administration, dosage forms and strengths, contraindications, warnings and precautions, adverse reactions, drug interactions, use in specific populations, pharmacology and clinical studies, handling and storage, as well as patient counseling.
Submitting a new drug application is a very time-consuming and expensive process with no guarantee for success. The use of filing strategies helps speed up the review process and ensure safety so the product gets on the market faster. To begin our NDA filing strategy, we held internal pre-NDA meetings to go over filing strategies, pre-NDA meetings with the FDA to review submission plans, and establish endpoints for the clinical trials. The last strategy we used was a risk management and evaluation strategy.
The purpose of our pre-NDA meetings are to highlight the things about our drugs that are going to allow for a speedy drug approval process. The competitor's product has an increased risk of respiratory depression, coma, and death. Clinical data show that Vicodix is a more efficacious and safe drug. Pre-NDA meetings are helpful in developing methods of presentation and submission of clinical data in a marketing application that facilitate the review and allow for timely FDA response. The endpoint that we use is a successful dose was defined as a dose of Vicodix that showed adequate analgesia with tolerable side effects and improved quality of life. A similar endpoint was used to our competitor who has similar indications. It is important for us to use similar endpoints of drugs already approved by the FDA so that the evaluation process of Vicodix's efficacy is accelerated. Risk management and evaluation strategies are included to manage known risk and potential risk associated with Vicodix. REMS requires a complete compliant education program that will be provided to healthcare providers. Patients will be educated on safe use, risk, storage, and disposal. Patients must be encouraged to read the medication guide and consider ways to improve safety.
Regulatory affairs extends beyond approval from the FDA. Our department plays an integral role in advertising, promotion review, and legal compliance. Pictured here is the package insert for Vicodix, prepared by our labeling review committee. These promotional review committees ensure compliance with IPHO's policies, voluntary industry codes, and anything that could possibly be of risk to the company. It is evident that industry pharmacists play critical roles in facilitating all stages of drug development and commercialization. They are involved in risk management and also regulate effective communications between FDA and IPHO interpretation. Pharmacists are of a great benefit to our department due to their unique training and extensive knowledge of medications. And now to Jennifer with Medical Affairs.
Thank you, Faith. Medical affairs plays a critical role during clinical trials, which is why IPHO Pharmaceuticals will consult with the medical affairs team beginning at phase 1 trials, as highlighted in the yellow in the bar graph displayed on the screen. Medical affairs provides input in crafting the proposed labeling language before FDA approval to maximize Vicodix value. Upon approval, medical affairs continues to support Vicodix, serving as the bridge between the company and its stakeholders. Here we would like to introduce the roles within medical affairs and their responsibilities in supporting Vicodix. First, we have myself as the head of medical writing and Angelica as the clinical project scientist supporting the research and development. As a head of medical writing, I am responsible for reviewing and preparing clinical and regulatory documents, including but not limited to clinical study protocols, investigator brochures, consent forms, investigational new drug applications, and drug safety update reports. As a clinical project scientist, Angelica serves as the liaison between VILO Pharmaceuticals and clinical investigators to direct study design, protocol development, and implementation of Vycotic's clinical studies in the late phase development. Next, we have Jelena as Medical Information Specialist and Grace as Director of Medical Publications and Communications, supporting the medical informations. As MI specialists, Jelena provides high-quality medical information to internal and external customers to ensure the safe use of Vycotics in compliance with VILO, corporate requirements, and regulatory requirements. In addition, Jelena serves to sit on the PRCs to ensure medical accuracy of all promotional materials produced. Next, Grace as Director of Medical Publications and Communications. Her primary responsibility is to lead and develop internal and external scientific communication contents for Vycotics. And then lastly, we have Anne as our medical advisor and Teresa as our principal medical science liaison, supporting the MSL team. As medical advisor, Anne is responsible for collaborating with the MSL team to develop scientific tools required for them to successfully perform their job. This may include creating and delivering brand training to the MSL teams. As principal medical science liaison, Teresa is responsible for maximizing Vycotics' value proposition through high scientific quality communications with key opinion leaders. She serves as a neuroscience expert responsible for discussing our product, patient treatment trends, and clinical studies involving Vycotics. Medical science liaisons provide information about off-label to our key opinion leaders upon request. This is especially important because off-label drug use is very common in the US. However, advertising without approval is considered misbranding.
As mentioned earlier, KOLs are an important aspect to the medical affairs team. In order to seek out potential KOLs, VILO attended conferences, some of which included national ones such as Pain Week and Business of Pain Medicine Conference. VILO also kept up with research journals to seek out potential KOLs as well. Once we had compiled a list of potential KOLs, we then used a selection criteria to assess them. As you see in this slide on the left-hand side, VILO assessed them based on their experience on their clinical practice, experience in publication record, experience in speaking, experience being on the scientific advisory board, and social media influence, and scored them according to this criteria. After evaluating the potential KOLs, VILO was able to narrow down the list to 10 potential KOLs, and we rank them. As you see here, on the right-hand side in the yellow section, the KOLs are ranked in order from 1 through 10. A KOL with a higher score is considered a better fit for the company. Along with the selection criteria, VILO also used a mapping device called Monocle to help us visualize the geographic relationship of the KOLs. We were then able to pick Dr. Robeck, Dr. Argoff, Dr. Perigolsky, Dr. Nalamachu, and Dr. Kao as our target thought leaders. Another important group of people are the external stakeholders. These include key organizations and payers. It is very important that VILO maintain a good relationship with these stakeholders to facilitate effective communication, because these individuals are responsible for the successful launching and implementing of Vycotics. VILO felt that a time frame of 12 months would be appropriate and ample time to provide all medical training and resources necessary to ensure confident use of Vycotics.
Pain medication, especially those with opioid properties, are often controversial and frightening to prescribers and patients alike. In order to ensure all medical affairs representatives are highly educated on the issue, internal stakeholder training and resources will be provided. Medical affairs will be trained on proper use, fraud, waste, and abuse. Specific trainings will include safe opioid prescribings for physicians and opioid-related continuing educations for pharmacists, nurses, and other healthcare professionals. Resources will be provided so that all medical affairs team members are versed in 1. Proper medication disposal of narcotics. 2. The medical affairs must be trained in proper pain assessment and ideal assessment tools that will be required to determine patient eligibility for this medication. These assessment tools will be those used in clinical trials and have proven efficacy in regards to medication. 3. The teams must be trained and aware of the proper response to questions regarding adverse events, especially that of dependency, and methods used in creating this medication that particularly prevent that based on the clinical trials and ongoing research evidence. 4. Review proper literature that highlight the superiority and non-inferiority of narcotics in comparison to alternatives is essential to the medical affairs personnel credibility. And lastly, 5, medical affairs teams members will be trained on all aspects of the medication package insert and internal funded clinical trials, as well as non-FDA approved indications, competing alternatives, results of the study not internally funded, HEOR data available or pending, and market implications and forecast. Industry pharmacists are valued in the medical affairs department as they serve as the drug experts in the Division of Medical Affairs. With extensive pharmacology knowledge, industry pharmacists and medical affairs are able to 1. Relay and provide clinical knowledge gained from trials, 2. Provide key opinion leaders with clinical and real-world outcomes to make sound clinical decisions for their patients, 3. Maintain professional relationships with KOLs on a peer-to-peer basis, 4. Develop health outcomes research for long-term data and return on investment for new molecules. And 5. Ensure that activities of the companies are in the interest of the patient. Overall, pharmacists educate members of the department, provide informational services to healthcare providers, and address any customer needs. And now on to health economics and outcomes research with Marisha.
Thank you, Jennifer, for the introduction. Health economics outcomes research, often known as HEOR, is a growing field that provides important information for making healthcare coverage and access decisions. With increasing access and utilization of healthcare, resources become more restricted, and prioritization for HEOR data has become more prevalent, which is why in recent years, HEOR is involved early in the drug discovery timeline. At Vilo Pharmaceuticals, our HEOR department supported narcotics beginning at phase 2 clinical trials.
Thank you, Marisha. HEOR is a discipline that is used to complement traditional clinical development information, including efficacy, safety, and quality, in order to guide decision makers regarding patient access to specific drugs and services. HEOR provides comparative effectiveness evidence to help healthcare payers with reimbursement and formulary decisions. Here at Vilo Pharmaceuticals, our HEOR team consists of myself, HEOR Director, and Marisha, Outcomes Liaison. HEOR Director develops and executes outcomes research to demonstrate the value of Vilo's products, including narcotics. This research includes budget impact analysis, real-world evidence studies, cost-effectiveness analyses, and EMR analysis. In addition, the director leads completion of systematic literature reviews, evidence dossiers, and value platform development plans. I present health outcomes research findings internally and externally via peer-reviewed process. Our outcomes liaison, Marisha, provides objective, specific, and clinical information to internal and external customers, including managed care organizations, large physician groups, group purchasing organizations, pharmacy benefit management companies, governmental agencies including CMS, Medicare and Medicaid, long-term care facilities, and integrated delivery networks, as well as accountable care organizations. Presented is Vilo's budget impact analysis projecting the cost-saving effectiveness of a 2-year span after narcotics is on the market. Within a healthcare plan with a population of 1,250,000 patients, Vilo projects to save $1,821,312 within the first year of entering the market. This is a decrease of $2.02 per member per month. The second year is projected to continue cost savings by an additional 20 cents on top of year one's reduction. This is probably due to a large number of members being prescribed Vycotics due to its effectiveness on improving quality of life in patients. VILO also projects a decrease in the cost of treatment and complications in patients with rheumatoid arthritis. On the left is shown via a pie chart Vycotics complication cost profile comparing the current year with an alternate year. On the right is a chart projecting cost savings on treatment for patients with RA. There is a $62,454 reduction after Vycotics enters the market. This is probably due to a higher adherence rate and improvement of quality of life because Vycotics is dosed less frequently with little to no CNS depression in comparison to other opioids.
The role of a pharmacist is vital in health economics and outcomes research due to several reasons. The primary reason being that they possess extensive clinical knowledge on medications and how it plays a role in the economy. Their jobs include they design and develop several economic and disease state models with their knowledge. They also publish, present to several journals, conferences, and to stakeholders. They also have a unique understanding of how pharmaceuticals are utilized at a patient level. And lastly, they're able to provide real-world effectiveness and product value. Overall, PharmD's unique understandings allow them to analyze the outcomes and present the results in a meaningful way, allowing them to play a vital role in HEOR. And now, on to marketing with Trong.
Thank you, Marissa. My name is Trường Do. I'm coming from the marketing department. So marketing functions start as early as the beginning of phase 2. Marketing department highly involved throughout the process of the product development by updating the team about the market demand. The responsibility of the marketing department is to develop a robust commercial strategy to successfully differentiate Vycotics among other competitors on the market. We achieve that goal by 3 steps. First, market research. 3, product presentation, and 3, market access. So for the first part, market research means that we're going to understand the market segment and evaluate the customer demand to create a tailored tactic strategy for the product. Second, we demonstrate the product value to the target audience by highlighting the key therapeutic and economic benefit. And last is develop the executive reimbursement plan to ensure the product access to the customer. So according to the CDC Wonder, more than 70,200 Americans died from a drug overdose in 2017, including illicit drug and prescription opioid. It's a 2-fold increase in a decade since 2007. In the left figure you see is a drug overdose death involving prescription opioids. There was about 500% increase in death incident from 1999 to 2017. Now you look at the orange line. Following it, you see the line showed the prescription for opioids and other synthetic narcotic, which is mainly fentanyl, has consistently increased since 2014. Now in the right figure, you can see according to the Agency of Healthcare Research and Quality in 2012, the number of hospitalizations due to opioid overdose had increased consistently over the years. Another research showing in 2016 published by the Medcare Journal, it looking at the data among the year 2013. It looked at the economic burden of prescription opioid overdose, abuse, and dependence in the United States. So the first thing we notice is the total economic burden is estimated to be about $78.5 billion. Over 1/3 of this amount is due to the increased healthcare and substance abuse treatment costs, around $30 billion. Looking at the pie chart, you can see the purple one, dark purple one, is represent the health insurance. It's 1/3 of them, and it represents that the economic burden for the opioid overdose, abuse, and dependence spent across all sectors in the society, from the health insurance to the patient quality of life. So in conclusion, after the market research, the market department conclude that there is a need in the market for a new drug that can reduce overdose-related costs for all parties, but do not sacrifice the therapeutic analgesic effect of the patient need. And next, I will introduce Joseph, our next member in the marketing team. Thank you.
Thank you, Trung. Here at VILO, we are trying to make the world a more productive place. We understand that to be more productive, you have to be able to operate at 100%. Those who are in pain are not able to perform at that high capacity. While traditional opioids help with the pain, they often have severe side effects which may hurt the patient in the long run. We wanted to create something that would truly help people and not hurt them. Our drug, Vicodix, was designed with patients, prescribers, and the public in mind. For patients, it's taken twice a day instead of every 4 to 6 hours. It also does not have the common side effects of other opioids. The most important thing to keep in mind for patients is that there are significantly lower risks, if any, of respiratory depression while taking Vicodix. For prescribers, Vicodix has a wide therapeutic range, and its unique mechanism of action as a partial mu agonist and formula make the drug hard to abuse, because manipulation will render the drug ineffective. And we also wanted to keep the public in mind. In the long run, we hope to see Vicodix be used as the first line of opioid analgesics to reduce the need for traditional opioids. This would prevent abusers from getting the drug and potential abusers from abusing the drugs. And here's Andre.
Thank you, Joseph. Today I'm going to talk about VILO's target audience. Our audience consists of 3 types: payers, primary care physicians, and patients. We prioritize most of our resources to payers and the least to patients. Within the 3 audience types, we have 4 subtypes. In the next few slides, I will go in more details about our strategies in classifying our targets. But on the right of the screen, I have a written explanation of each classification. Vicodix lovers is highlighted in red because they understand and like Vicodix, so there's no need to target them. Vicodix skeptics, they understand Vicodix and decided not to use Vicodix. So there's also a reason why we shouldn't target them. Vicodix naive, they're not aware of Vicodix, so they offer the most potential on ability to influence. So we will use our most resources to target them. Vicodix indifferent, they're aware of Vicodix, but they're on the fence of forming an opinion, so it is critical to target them to help persuade them to be Vicodix lovers. As far as targeting our payers, we will reach out to PBMs before the drug is on the market and after the drug is on the market. Before it's on the market, we will use projected cost effectiveness data from the budget impact analysis. And after our drug is on the market, we will use our established trends and financial data also from the budget impact analysis. Our primary care physicians will have our MSLs give surveys to our PCPs while they're on their regular visits. And then also for patients, we'll have flyers in high volume areas, offering a reward for patients to answer surveys.
Segmented models were used to identify our ideal target audience for our product. Our first set of segmented models are for our payers. On the left, we have our payer Vicodix naive. On the right, we have our payer Vicodix indifferent. Like mentioned on the previous slide, we reached out to PBMs and presented to them our budget impact analysis. After our presentation, we then follow up with survey questions. Our survey questions were non-open-ended response questions, including but not limited to, have you heard of Vicodix prior to the survey? And open-ended response discussions conducted by a moderator that asks questions like, what about Vicodix don't you like? What do you like most? Each survey participant was then scored based on their response, which then determined if they were naive or indifferent. Next, their demographics were taken to develop a trend or correlation between naive targets and indifferent targets, which can be seen on the left of the segmented model. On the right of the segmented model, we took into account their behavior aspects. For example, usage, meaning what other drugs on their formulary treats rheumatoid arthritis. Loyalty, are they willing to add another drug to their formulary? Interests, likes, what do they say they like most about our product? Then once all the data is collected, we now have all the target information we need in order to effectively relay our message to our targets.
Next, we have our target audience PCPs. We have 2 more segmented models. On the left, we have our PCP Vicodix naive, and on the right, we have our PCP Vicodix indifferent. We have 2 ways to reach out to PCPs. First, VILO will host conferences open to PCPs, including KOLs. In a couple more slides, more details will be given about this conference, but for now, I just want to say that the conference will raise awareness to the current state and burden of the opioid epidemic to our society. And also we'll have panels to discuss common side effects and how to manage opioid use and introduce our product as a potential solution to prevent all of those consequences. Then we'll follow up with surveys, similar to the surveys that we gave to the payers. Our second way we'll reach out to PCPs is having our MSLs give surveys to the PCPs during their regular visits. Again, the surveys will have non-open-ended responses, including have you heard of Vycotics prior to the survey? Have you prescribed Vycotics prior to the survey? Will you prescribe Vycotics after this survey? Would you recommend Vycotics to a patient who experiences severe adverse effects while on a different opioid treatment? And also open-ended response questions, also conducted by a moderator. How do you feel about the current opioid crisis? What about Vycotics don't you like? What do you like most about Vycotics? And how prevalent is respiratory depression in your community? Again, after each survey participant is scored, based on their responses, we will determine if they're naive or indifferent. Also, we'll, just like the payers, we'll use their demographic information to develop trends and correlations between naive targets and indifferent targets. Also, we'll take into account behavior. An extension of the payer segmented model, we now added the opioid epidemic awareness and prescription pattern. We want to gauge how seriously the PCP is taking the opioid crisis. Once the drug is on the market, we want to see how often they prescribe our product. If it's a high volume of prescriptions, they are a lover and they will no longer be targeted. If they knew about our drug prior to the survey and they have a low volume prescription rate, we want to follow up to ask why that is the case. And based on their response, we will determine if they are indifferent or skeptical. We also want to know their psychograph information, especially their values and social media presence. We want to know what they value when treating patients, safety, or efficacy. We also want to know their social media presence so that if they are active on social media, they can potentially influence the public with their posts. PCPs who are active on social media give us another outlet to educate the public about our product. Now we have our target audience patients segmented models. On the left, we have the patient Vycotics naive. On the right, we have our patient Vycotics indifferent. Patients are also invited to the same conference that we invite the PCPs and the KOLs. And after the conference is concluded, we also give our patients surveys. And the non-open-ended responses survey questions include, have you used Vycotics prior to the survey? Do you know someone who has died from respiratory depression? Will you use Vycotics after the survey? Will you recommend Vycotics to a family member or friends in the future? Our open-ended response questions include, how do you feel about the current opioid crisis? How did you hear about Vycotics? What about Vycotics don't you like? What do you like most about Vycotics? Each survey participant is again scored based on their response to determine if they're naive or indifferent. Then their demographics are taken to develop a trend correlation between the naive targets and the indifferent targets. Behavior is also taken into account once again, and we also want to know about their spending patterns, if they're non-insured, their mode of payment, especially if they're non-insured, if they're paying out of pocket. We want to know if they're price sensitive or brand sensitive, if they have a preference to a certain brand, or if they're indifferent. We also want to know their psychographic information, safety, or efficacy. We want to know social media presence as well because they offer us a potential outlet to educate the public about our product. Now here's Joshua.
Thank you, Andre. Vilo's core strategy will involve the use of sales representatives that mostly will target payers and providers. We will conduct research to determine Which providers have a significant percentage of their scripts written for chronic pain and create relationships and network with these providers. Areas of great interest are hospitals and clinics that specialize in chronic pain. Sales representatives will also approach payers and PBMs to discuss the benefits of Vycotics and get a better position for when we negotiate formulary tiers and rebates. A strategy that Vylo will use to approach the market will be holding multiple conferences in large cities across the nation. It's not a surprise that chronic pain competitive landscape is incredibly saturated, and there are plenty of competitors that have already established footholds in the pharmaceutical industry. Vylo will place its main branding goals on making a difference in the opioid epidemic. In doing so, we hope to differentiate our company from our competitors by showing that we place a higher priority in helping the community than just simply profit. Making a conference that is specifically geared towards the opioid epidemic will allow us to show our dedication to the issue and show that we offer a solution that can potentially affect the entire world, much less the nation. The goal of holding conferences in general is to gain traction for Vycotics so that we can garner support from the communities. This will allow our sales representatives to have a clear introduction to show providers and PBMs about the massive response the community will have to Vycotics. Ideally, we would invite patients, families, insurers, and healthcare providers to the conference by opening it up to the public. We would ask each group to designate themselves as each category so that questions and discussions can take place. Keynote speakers from each group would be asked to speak on their experiences and what they think a solution looks like or what is hindering the progress in terms of the opioid epidemic itself. Finally, the conference would of course reveal Vycotics and its purpose of helping chronic pain while also decreasing addiction and deaths due to respiratory depression. We would have panels of directors who worked on Vycotics to answer questions about what the drug is and how it's on a different playing field compared to the other competitors. In industry, a multitude of individuals work in cohesion to develop and to bring a drug to market. Each person plays a critical part that only they can achieve to maximum efficiency. This is, of course, no different for the industry pharmacists. Industry pharmacists play a key role in the business development, planning, marketing, market access, and post-market research. In terms of business development, it is the industry pharmacist's key duty to relay to their teams what clinical trial structures to use in order to optimize market opportunities. In regards to marketing, developing a brand strategy that differentiates between the competitors is another key role of the industry pharmacist. They are the bridge between marketing and development to determine how to market the medication in a way that shows how their drug is different. This is especially crucial in a very saturated and delicate market. Market access deals with how to approach the market and audiences and in what way to execute. In regards to our company, our market access begins by approaching the PBMs in order to allow Vycotics the optimal chance of accessing the market. Finally, post-marketing research is another important duty of the industry pharmacist. Creating surveys and making calls to patients to determine outcomes and satisfactory levels will allow the company to determine what changes must be made in order to improve Vycotics' foot in the community. Here at Vylo, we are well aware that researching, developing, and marketing a new drug is very much a group effort. Even if one team fails, the entire process becomes delayed. We also believe this holds true for the opioid epidemic as well. Even if we believe Vycotics can make a difference in the opioid epidemic, it still takes insurers, healthcare providers, patients, friends, and their families to be ready and willing to work together to achieve a common goal. We hope a conference can get that ball rolling, because here at Vylo we believe that together we can move forward. And now, in collaboration with marketing, medical affairs, and regulatory affairs, we'd like to introduce our direct-to-consumer commercial.
Does rheumatoid arthritis stop you from being the best you? Does the pain get in the way of you being active? Does it stop you from spending time with loved ones and enjoying the little things in life? Introducing Vycotics, the newest opioid drug that treats chronic rheumatoid arthritis pain while reducing severe side effects of traditional opioids, such as constipation, respiratory depression, sedation, and addiction. Taken twice daily, Vycotics will allow you to treat your pain and lets you get back to being active, spending time with loved ones, and enjoying the little things in life. Be your best you with Vycotics, available by prescription only.